Hi guys, good morning. So today we are going to start our new subject, that is the general pathology. In general pathology, first we are going to cover our first unit, that is the cell pathology or the cellular pathology. So starting with the cell injury. So basically what is cell injury? So it is defined as a variety of stresses a cell encounters as a result of the internal or the external environmental changes. This is known as the cell injury. So cell injury, it is common to all the pathological processes. The cell injury, it results from a disruption of one or more of the cellular components that maintain the cell viability. Coming on to the etiology of cell injury. So basically the cell injury, it is of two types: the reversible injury and the irreversible injury. Fine. So these reversible and irreversible, they are broadly classified into two large groups. Number one cause is the genetic cause. Second is the acquired cause. Acquired causes. So guys, genetic causes, we are going to study the genetic causes in a separate lecture. So here we are going to discuss about all the acquired causes. So in this we have hypoxia and ischemia. We have physical agents, chemicals and the drugs, microbial agent, immunologic agents, nutritional derangement, psychogenic diseases, iatrogenic causes and the idiopathic diseases. These all are the acquired causes. We'll be discussing them one by one. Let's discuss the common cellular response to cell injury. This is the basic cellular response. See, this is the normal cell. When there is altered functional demand, it leads to certain cellular adaptations, which includes the hypertrophy and atrophy, which means increase or decrease in the cell size. The hyperplasia, it means increased number of cells. The metaplasia, it means change of the cell from one type to another type. And dysplasia, it means changed the phenotypic differentiation. Fine. So these all are the cellular adaptation which takes place, and when the stress is removed, the normal cell is restored, or the cell is restored to its normal shape and size. Coming on to the second one, when the normal cell, it leads to mild to moderate stress, then the result will be the reversible cell injury, which leads to degenerations, subcellular alterations and intracellular accumulation. And when the stress is removed from the normal cell, it leads to repair and healing. While the third condition, when the normal cell, it leads to severe and persistent stress, it leads to irreversible cell injury, which finally leads to cell death. Right? This is the common cellular response to the cell injury. So starting with the reversible injury. So in the reversible injury, the mitochondrial oxidative phosphorylation, it is disrupted first, which leads to decrease in the ATP, and which further leads to decrease of the sodium and the potassium ATPase, which results in the gain of the intracellular sodium and leads to cell swelling. Second is when there is a decreased ATP dependent calcium pump, it leads to increased cytoplasmic calcium concentration. While when there is altered metabolism, it leads to the depletion of the glycogen, and when there is a lactic acid accumulation, it leads to decreased in the pH. The detachment of the ribosomes from the RER leads to decrease in the protein synthesis. So the end result is the cytoskeletal disruption with the loss of the microvilli, and there are the bleb formations, etc. Fine. So this is what we called as a reversible injury. Now coming on to the irreversible injury. So in this, the mitochondrial swelling with the formation of a large amorphous density in the matrix, the lysosomal membrane damage which leads to the leakage of the proteolytic enzyme into the cytoplasm. And in the irreversible injury, the mechanism, it includes the irreversible mitochondrial dysfunction which leads to markedly decrease in ATP, and this the severe impairment of the cellular and the organelle membrane. Now first is the hypoxia and ischemia. So in this, as you know that the cells of the different tissues, these are essentially require the oxygen to generate and perform the metabolic function. Right? When there is deficiency of oxygen, or you can say when there is an hypoxia, it results to the failure to carry out all these activities. Fine. So the hypoxia, it is the most common cause of all kind of injuries, and the causes of hypoxia are: number 1, the ischemia, the anemia, the carbon monoxide poisoning, cardiorespiratory insufficiency, and there is increased demand of the tissues, and the cerebral infarction, myocardial infarction, and the renal atrophy. Right? Now after this, see, this is ischemia, and this is the mitochondria in which there is decreased oxidative phosphorylation, which results in decrease in the ATP. Now from this, it leads to 3 conditions. Number 1, there is decreased sodium pump, which leads to increased influx of the calcium, H2O and sodium, and increased efflux of the potassium, which leads to the ER swelling, or the cellular swelling, or the loss of the microvilli or the blebs. These are the blebs. Fine. Number 1, this condition. Second is there is increased anaerobic glycolysis, which leads to decreased glycogen, increased lactic acid, and decreased pH. And when there is a decrease in the pH, it leads to the clumping of the nuclear chromatin. Third condition, there is a detachment of the ribosomes, which leads to the decreased protein synthesis and finally leads to lipid deposition. Right? Second cause is due to the infectious diseases like the tuberculosis, the actinomycosis, the candidiasis on the tongue, and the primary herpes. And the third causes are the physical injury. Now physical agents or the physical injury are: number one, the mechanical trauma, example the road accidents. Due to the thermal trauma, example heat and cold. See in this is the thermal trauma or the thermal burn. Third is due to electricity or due to radiations, whether the ultraviolet or the ionizing radiation. And last is the rapid changes in the atmospheric pressure. Fine. And it is also due to the traumatic ulcer. So after this, next are the injuries due to the chemicals or the drug, such as the chemical poisons like the cyanide, the arsenic, mercury, strong acids and alkalis, due to the environmental pollutants, due to the insecticides and the pesticides, due to the oxidation at high temperature, and due to the hypertonic glucose and salt. And in the photograph you can see there is an aspirin burn. So after this, next are the maybe due to the microbial agents. The microbial agents, in this the injuries by the microbes, or it also includes the infections which are caused by the bacteria, the viruses, the fungi, the protozoas, metazoas and other parasites. So in this, all the infection which are caused by these microbes. Fifth one is the immunological agent. Due to immunological agents, it may be due to hypersensitivity reactions, it may be due to anaphylactic reactions, or it may be due to autoimmune diseases. Fine. Last is the last cause. It may be due to the nutritional derangements, in which there is the nutritional deficiency diseases. It may be due to the deficiency of the nutrients, example the starvation of protein or calorie, which leads to marasmus and the kwashiorkor. Right? The marasmus and the kwashiorkor of the minerals may be due to anemia. So these all are the etiology or the causative agent or the acquired causes of the injury, cell injury. Now after this, let's discuss the pathogenesis of the cell injury. So first we are going to discuss about the general principle of the pathogenesis. So in this, the type, the duration and the severity of the injurious agents, the type, status and adaptability of the target cell, the underlying intracellular phenomena, example the mitochondrial damage, the cell wall damage and the free radicals. And fourth one are the morphological consequences, which includes the ultrastructure changes and the swellings. So first is the pathogenesis of the ischemic and the hypoxic injury the reversible cell injury. So in this there is decreased generation of the cellular ATP, which leads to intracellular lactic acidosis in a nuclear clumping, finally leads to nuclear clumping. Then there is a damage to the plasma membrane pump, in which there is ATP dependent sodium pump and the calcium pump. So in this there are damage to the plasma membrane pump. And finally the reduced protein synthesis, which leads to the dispersed ribosomes. Fine. See, due to hypoxia and ischemia, there is decreased ATP, which leads to decrease the intracellular pH in the cytosol. Fine. Which leads to the ultra-structural functional changes, and finally the reversible cell injury takes place. While second is due to decreased ATP, there is a damage of the sodium pump in the membrane. See, damage to the plasma membrane group, which includes the ATP dependent sodium potassium pump and the calcium pump, which leads to the ultra-structural functional changes, and it finally leads to reversible cell injury. Third is when there is a decreased protein synthesis in the RAR, it leads to the ultrastructure functional changes, and it finally leads to the reversible cell injury. Now next is the irreversible injury. So the mitochondrial damage, it leads to increased calcium influx. The activated phospholipase leads to membrane damage. The intracellular proteases leads to cytoskeletal damage, while the activated endonucleases, it leads to the nuclear damage. See, this is the consequences or the sequences of the event in the pathogenesis of the irreversible cell injury in ischemia. So when there is an ischemia or hypoxia, it leads to decrease in the ATP generation, and there are three conditions. Number one, when there is a decrease in the ATP generation, it leads to decrease in the synthesis of the membrane phospholipid, which leads to increase in the loss of the membrane phospholipid, and it leads to the membrane damage. And further, there is a liberation of the intracellular enzyme, which leads to three changes: the nuclear changes, cell death, and the serum enzyme estimation. While in the second condition, when there is a decreased ATP generation, it leads to increased systolic calcium ions, and with the reperfusion in the mitochondria, there is increased calcium ions, which leads to increased systolic calcium ions. And there are two conditions: the phospholipase activation, which increase the loss of the membrane phospholipid, while second is the lipid breakdown product, which leads to the membrane damage. And second, when there is an increased systolic calcium ion, there is a protein activation, which leads to the cytoskeletal injury, and which finally leads to the membrane damage. While the third condition, when there is a decrease in the generation of ATP, there is a toxic oxygen radicals. With the reperfusion, there is a formation of oxygen, the hydrogen peroxide, and the OH ions. Fine. And it leads to the lipid peroxidation and the DNA damage, which finally leads to membrane damage. And in the membrane damage, there is a liberation of the intracellular enzyme, which leads to the nuclear changes like the pycnosis, the karyolysis, and the karyohexis. While there is a cell death, the myelin figures, and the serum enzyme estimation, the SGOT, LDH, the CPK, MB, and CTN. So this is the cellular events or the possible sequence of the event in the pathogenesis of the irreversible cell injury. So after this is the normal differentiation between a organelles in the normal cell, a reversible cell injury, and a irreversible cell injury. So first is the mitochondria. So mitochondria, it is normal in the normal cell structure or the normal organelles, while in the reversible cell there is a swelling and there's an amorphous densities. These are the densities. While in the irreversible, there are swollen with the vacuoles and there are large densities. In the reversible, there are amorphous densities or small densities, while in the irreversible cell injury, there are large densities. Second is the membrane, which is normal in the normal cell organ as a normal cell organelles, while in the reversible cell, the formation of the blebs. These are the blebs. Right? There is the intramembranous particles. These are the myelin figures, and this is the cell swelling. While in the irreversible cell injury, there are the myelin figures. These are the myelin figures, and there is disruption, but there is no bleb formation. While in the RER and the ribosomes, in the reversible cell injury, there are swelling. There is dispensed ribosomes. While in the irreversible, these are lysed and there is dispersed ribosomes. While the lysosomes, in the reversible cell injury, there is autophagy, while in this irreversible, they are swollen and fractured. Cytoskeleton, in the reversible cell injury, it is aggregated, while in the irreversible, these are disruptive or the disrupted. While the nucleus, in the reversible cell injury, these are clumped chromatin, while the irreversible cell injury, there is pycnosis, karyolysis and the karyohexis. Right? So this is the difference between all the organelles between the reversible and the irreversible cell injuries. So after this, let's discuss the ischemia reperfusion injury and the free radical mediated cell injury. So in this, there are different consequences from ischemia to the reversible injury, from ischemia to the reperfusion injury, from the ischemia to the irreversible injury. These are the three possible consequences. Coming on to the mechanism, when there is a calcium overload, it leads to the increased lipid peroxidation of the cell membrane. When there is a generation of the ROS and subsequently inflammatory reaction, neutrophils utilize the oxygen and gives the free radicals. Right? Now after this, let's discuss about the free radicals. So the free radicals, these have an unpaired electron in their outer orbit. The free radicals, these cause the chain reactions. Important. These are generated by the absorption of the radiant energy, the oxidation of the endogenous constituents and the oxidation of the exogenous compounds. Important. Now, what all are the examples of the free radical injury? So the examples are the chemical example, the CCl4, the acetaminophen, the inflammation or the microbial killing. The irradiation includes your ultraviolet rays and the skin, which leads to skin cancer. The oxygen example, the exposure to a very high oxygen tension on the ventilator and the age related changes. Now coming on to the mechanism of the free radical injury. So there is a lipid peroxidation which leads to the cellular or the organular membranes. When there is a protein cross-linking, fragmentation due to the oxidative modification of the amino acids and the protein. Important. The DNA damage it's due to the reaction of the free radical with the thymine. Important for your MCQ. See, this is the structure of a mitochondria. When there is an oxygen, there is an incomplete reduction which leads to the superoxide. Fine, there is an inflammation, radiation, chemical reperfusion injury. These all are the causes which leads to the superoxide, and the superoxide, it further forms the H2O2 hydrogen peroxide, and the hydrogen peroxide, it leads to hydroxyl radical with the help of the Fenton reaction. So the hydroxyl radical, this is reactive oxygen species. Fine. So the hydroxyl radical, it leads to important lipid peroxidation. It leads to protein oxidation. It leads to DNA damage, and it leads to cytoskeletal damage, and these all leads to cell death. Fine. Now the pathologic effects of the ROS, cell injury and the death. So the ROS, it reacts with the fatty acid and causes the oxidation, which leads to generation of the lipid peroxidase, and finally there is disruption of the plasma membrane and the organelles. While the proteins, it leads to the oxidation, which further leads to the loss of the enzymatic activity and the abnormal folding. While the DNA, it leads to the oxidation and mutation. Now next is the removal of the free radicals. So the antioxidant mechanism, the superoxide in the mitochondria, it converts the O2 plus into the hydrogen peroxide. The glutathione peroxidase in the mitochondria, it converts the hydroxyl radical into the hydrogen peroxide, and it gets splits into the water and the oxygen. See, the hydroxyl group, it get converted into H2O2 with the help of the glutathione peroxidase, and the H2O2, the hydrogen peroxide, it gets splits into water and oxygen. The catalase in the peroxisomes, it converts the H2O2 into with the help of the catalase, the H2O2, it gets splits or it gets converts from H2O2 to water and oxygen. So after this, the pathogenesis of the chemical injury. So in this we have the direct cytotoxic effect. The direct cytotoxic effect with the HGC1-2 poisoning and anti-cancer agents, important for your MCQ. The conversion to reactive toxic metabolites. The metabolites kill the cell, example the CCl4. These affects the liver, and acetaminophen poisoning, as we have already discussed this. So the pathogenesis of the physical injury, it may be due to the ultraviolet rays, or it may be due to the ionizing radiation. So the ionizing radiation in the cell membrane, and it leads to the DNA damage. So the ionizing radiation, in this there is killing of the cells by the ionizing radiation. It is a result of the direct formation of the hydroxyl radical from the process of the radiolysis of the water. So there is direct formation of the hydroxyl group with the process of the radiolysis of the water. Fine. So these hydroxyl, so this hydroxyl radicals, they damage the cell membrane, as well as they may interact with the DNA of the target cell, and it leads in the proliferating cells like in the epithelial cells, which leads to the DNA damage, and which further results in the inhibition of the DNA, and with the help of the apoptosis, it leads to cell death. So apoptosis is the programmed cell death. Fine. Secondly, in the non-proliferating cells, example the neuron. So in this there is a lipid peroxidation takes place, which leads to damage of the cell membrane, and with the process of the necrosis, it finally leads to cell death. Fine. So after this, now coming on to the cellular adaptations. So the cellular adaptation, it is a state that lies intermediate between the normal unstressed cell and the injured overstressed cell. So the cell can adapt themselves by undergoing these 5 conditions. Number 1 is the hyperplasia. Hyperplasia, it means that there is an increased number of cells. Hypertrophy and atrophy, it means that there is an increase or decrease cell size. Metaplasia, it means that there is a change from one type to another type. And the dysplasia, it means there is a change phenotypic differentiation. Okay. So let's discuss them one by one, starting with the atrophy. So atrophy, it is an acquired loss of the size due to the reduction of the cell size or number of parenchyma cells in an organ. So in this, there is a decrease in the cell size. So it can occur in the 2 ways. So atrophy, it can occur in the 2 ways. It may be the physiological atrophy or it may be the pathological atrophy. So the physiological atrophy, in this, the normal process of the aging in some tissues, which could be due to the loss of the endocrine stimulation, or it may be due to the arteriosclerosis. Fine. So in this, there may be atrophy of the lymphoid tissues, atrophy of lymphoid tissues in the lymph node. There may be atrophy of the gonads after menopause, and it may be atrophy of the brain with aging. Fine. So this is all about the physiologic atrophy. Now second is the pathologic atrophy. So in this, there is a starvation atrophy, ischemic atrophy, example the atrophic kidney, the disuse atrophy, example the atrophy of the pancreas, the neuropathic atrophy, example the motor neuron disease, MOD, and the endocrine atrophy, example the atrophy of the thyroid and adrenal gland. Okay. So after this, next is the hypertrophy. So hypertrophy, it leads to the increase in the cell size. With such change, then when there is an increase in the size of the organ, see, when there is an increase in the size of the organ, it is automatically there is an increase in the in the size of the cell. So the types, it is also of 2 types, the physiologic and the pathological. So the physiological causes in this, the physiologic growth of the uterus during the pregnancy, it involves both the hypertrophy and the hyperplasia. While the pathological causes, there is a hypertrophy of the cardiac muscle, hypertrophy of the smooth muscle, which leads to the cardiac achalasia, the pyloric stenosis, intestinal strictures, the muscular arteries in hypertension, and it is also due to the hypertrophy of the skeletal muscle. And last is the compensatory hypertrophy. In this example is nephrectomy of one side and removal of the one adrenal gland. So third is the hyperplasia. So this is a temporary increase, important. The temporary increase in the number of the parenchymal cells resulting in the enlargement of the organ. Often hypertrophy and hyperplasia, these occur simultaneously. It occurs due to increase in the mitosis of the resting cell. What is the cause of the hyperplasia? The hyperplasia, it may be occur due to increase in the mitosis of the resting cells. Important. The neoplasia causes the change in the genetic composition of the cells. So the causes, it may be physiological, it may be pathological. So the physiological hyperplasia, number one is the hormonal hyperplasia. Example, when there is an increased size of the breast during the pregnancy and the lactation, it is a pregnant and the pregnant uterus. Second is the compensatory hyperplasia. Example, in the regeneration of the liver cells after the hepectomy, epidermis after the skin abrasion. While the pathological hyperplasia, see, this is the hyperplasia. Now the pathological hyperplasia, number one, in the endometrial hyperplasia, in excess estrogen, in wound healing, there is a proliferation of the fibroblast cells and the formation of the skin warts like the papilloma viral infection. Fourth is the metaplasia. So metaplasia, it is defined as a reversible change, important, of one type of the epithelial or the mesenchymal cells to another type of the adult epithelium or the mesenchymal cells. So it has a long time metaplasia in which it may result in cancer. If a patient is having a long time metaplasia, so the result will be cancer. So it is divided into two types, the epithelial metaplasia and the mesenchymal metaplasia. So epithelial metaplasia, in which number one is the squamous metaplasia. Example, in the bronchus of the chronic smokers and the uterus of the old age. While the columnar metaplasia, example, is the intestinal metaplasia in a healed chronic gastric ulcer. Guys, examples are very important for your MCQ point of view. Please remember the examples. While the mesenchymal metaplasia, the osseous metaplasia, example is the arterial wall in the old age, and the cartilaginous metaplasia, example, the healing of the fractures. And last is the dysplasia. So dysplasia, it means disordered, irregularly or disordered. So this is in an ordered and this is in a disordered fashion or disordered arrangement. So dysplasia, it means the disordered cellular development. It is often accompanied with the metaplasia and with the hyperplasia. It often occurs in the epithelial cells, and their characteristics are, there is an increased number of layer of the epithelial cells. There is an increased mitotic activity, the disorderly arrangement of the cell from the basal layer to the surface layer. So from the basal layer to the surface layer, there is a disordered arrangement of the cells. The cellular and the nuclear pleomorphism, variability in the size, shape, staining of the cells or in their nuclei. Fine. So this is all about the cellular adaptation. So after this, important is the difference between a metaplasia and a dysplasia. So by definition, the metaplasia, it is the change of one type of epithelial or the mesenchymal cells to another type of the adult epithelial and the mesenchymal cell. While the dysplasia, it is the disordered cellular development which may be accompanied with the hyperplasia or with the metaplasia. So the type of the metaplasia, it is epithelial and mesenchymal, while dysplasia, it is epithelial only. The tissue affected in the metaplasia most commonly affects the bronchial mucosa, the uterine and the endocervix, and other mesenchymal tissues like the cartilage and the arteries, while the dysplasia, the most commonly affect is uterine, cervix and bronchial mucosa. While the cellular changes in the metaplasia, it is the mature cellular development, while in the dysplasia, there is disordered cellular development, there is pleomorphism, nuclear hyperchromasia, mitosis, in which there is a loss of polarity. While the natural history, it may be in the metaplasia, it is reversible on the withdrawal of the stimulus, while in the dysplasia, it may regress on the removal of the inciting stimulus, or it may progress to the higher grade of the dysplasia or infect the cancer or the carcinoma in situ. Now coming on to the morphology of the cell injury. So cell injury, as you all know, there is reversible cell injury and irreversible cell injury. Cell death The necrosis is the cell death and apoptosis is the programmed cell death. Starting with the morphology of the reversible cell injury. So the cell swelling, it develops when the cell are incapable of the fluid or an ion hemostasis, in which there is a decreased function of ATP dependent pumps. The fatty change, in fatty changes, the accumulation of the lipid vacuoles in the cytoplasm are oftenly seen. So in this there are 4 types of changes. The hydropic changes, in which there is a swelling in the kidney, liver and the pancreas. The hyaline changes, it is a glass-like. The mucoid changes, it is a mucus. And in the fatty changes, it is a fat accumulation, example in the fatty liver. While in this we have the light microscopic changes and the ultrastructural changes. So in the light microscopic changes, there is a cell swelling which is also called as hydropic change, and in this you can also see there is a fatty change. While in the ultrastructural changes, there are alteration of the cell membrane important. There is a swelling of and a small amorphous deposits in the mitochondria. There is a swelling of the RER and the detachment of the ribosomes. See, detachment of the ribosome, as we have already seen in the diagram. See, in this there is a disperse or detachment of ribosomes and there is a swelling. Right? So next is the morphology of the irreversible cell injury. So the irreversible injury, it is also called as necrosis, in which there are 2 basic processes which underlie the morphologic changes of the necrosis. Important, number 1 is the denaturation of the protein and the enzymatic digestion of the cell component. There are autolysis or the self-digestion, necrosis, apoptosis, gangrene and calcification. So in the light microscopic changes, there is an increased cytoplasmic eosinophilia, which leads to the loss of the RNA, which is more basophilic, the cytoplasmic vacuolization and the nuclear chromatic clumping. While in the ultrastructural changes, there are break in the cellular and the organellar membrane and the large amorphous densities in the mitochondria, and in this you can also see the nuclear changes. Now what all are the nuclear changes? The pycnosis, which means the nuclear shrinkage with the increased basophilia. Guys, these terminologies are very important. The karyohesics, in which there is a fragmentation of the pycnotic nucleus, and the karyolysis, in which there is a fading of the basophilia of chromatin. Very important. Please understand the difference between these 3 nuclear changes. See, this is the normal cell. Fine. This is the reversible cell injury. When there is an injury in the normal cell, it leads to the swelling of the endoplasmic reticulum and the mitochondria. Swelling in the endoplasmic reticulum and swelling in the mitochondria, which leads and also leads to clumping of the chromatin. And when the stress is removed, and or you can say when there is a recovery, it leads to the normal cell, or it converts back into the normal cell. While in the irreversible cell injury, which leads to necrosis, when there is an injury to a normal cell, it leads to the swelling of the endoplasmic reticulum and there are loss of ribosomes, and the lysosome, this get ruptured, and these are the membrane blebs, these are formed, and these are the myelin figures, the swollen mitochondria with the amorphous densities, and there is a nuclear condensation which leads to necrosis. There is a fragmentation of the cell membrane and nucleus. So this is the difference between a reversible cell injury and irreversible cell injury. Now coming on to the types of the cell death. So in this we have two terminologies which are important, the apoptosis and the necrosis. So apoptosis, it is a form of a coordinated and internally programmed cell death. Important. Right? Apoptosis is a Greek word which means the falling off. Falling off. Fine? Falling off, or you can say dropping off. So this is a term which was first coined in 1972 as the distinct from the necrosis. Important is it is coined in 1972. So it is usually a regulated controlled process. So it plays a role in the embryogenesis. Coming on to the necrosis. So necrosis, it is always pathologic, and the result, it is a result of the irreversible injury, and there are numerous causes of the necrosis. So first we are going to discuss about the apoptosis. So apoptosis, it occurs in the two processes, the physiological and the pathological process. So in the physiological process, it is during the development of the embryo. It takes place during the development of the embryo. The cells of the hormone, it depends upon the tissues. Example, the endometrial shedding, regression of the lactating breast, and the involution of the thymus gland in early age. Important. While the pathological processes in this, the cell death in the tumor which exposed to the when it is exposed to the chemotherapeutic agents, the cell death by the cytotoxic T cells in the graft rejection, the progressive depletion of the CD4 cells in the AIDS, while the cell death in the viral infection, the pathological atrophy, the cell death after the exposure of the radiations, hypoxia. The degenerative diseases of the CNS like the Alzheimer's disease and the heart disease. These all are the pathological process of the apoptosis. Now coming on to the morphology of the apoptosis. So in this, there is chromatin condensation which leads to the progressive cell shrinkage, and in this there are formation of the blebbing, or the blebs are formed from the plasma membrane, and these are the apoptotic bodies, and this is the process of the phagocytosis if there is no inflammation. Fine. So this is the morphology of the apoptosis. See, this is the normal cell. There is a condensation of the chromatin, and these are the formation of the plasma membrane, or the formation of the membrane blebs, and there is the cellular fragmentation. These are the apoptotic bodies. This is known as apoptosis, and this is the phagocyte with the process of the phagocytosis of the apoptotic cells and the fragments. Fine. Now these are the apoptosis, the smallest apoptosis. So after the apoptosis, next is the necrosis. So the type of the necrosis, it is always dependent upon the pattern of the enzymatic degradation of the cells and the extracellular matrix. So the type of the necrotic debris and by bacterial products when they are present. So next are the types of the necrosis: coagulative, liquefactive, caseous, your fat necrosis, and gangrenous necrosis, and fibrinoid necrosis. Fine. If a question comes, which of the following is the most common type of necrosis? So your answer should be coagulative. Starting with the coagulative necrosis, so in this, the cell's basic outline is preserved. The outline is preserved. The homogeneous glassy eosinophilic appearance due to the loss of the cytoplasmic RNA, which is basophilic, and the glycogen, which is granular. Important point. The nucleus, it may show the pycnosis, carolysis and the karyohexis. It is caused by the irreversible focal injury or due to ischemia. In this, the foci, these are pale, firm and slightly swollen. The hallmark is the presence of the tombstone, important for your MCQ. The tombstone appearance. Next is the liquefaction necrosis. It is usually due to the enzymatic dissolution of the necrotic cell, which is usually due to the release of the proteolytic enzyme from the neutrophils. Important. Most often seen in the CNS and in the abscess. It is caused due to ischemic injury or the bacterial infection, example the infarct brain. The affected area, it is soft, containing the necrotic debris. While in the caseous necrosis, it resembles like a cheese. So it is amorphous, granular, eosinophilic material which is surrounded by a rim of the inflammatory cells. There are no visible cell outline. The tissue architecture is obliterated. It is usually seen in the infection, especially with the infection of the mycobacterial and the fungal infections. Found in the foci of the tuberculosis infection, important, in which there is having the feature of the coagulative and the liquefaction necrosis. It appears like a dry cheese, soft, granular and yellowish. Next is the fat necrosis. So it results from the hydrolytic action of the lipases on the fat. It is mostly seen or most oftenly seen in and around the pancreas, important, and can also be seen in the other fatty areas of the body, usually due to the trauma. So in this, the fatty acid, it released via the hydrolysis reaction with the calcium to form the chalky white areas, which is called as the saponification. Very important. There is a presence of the pancreas. It is present at the pancreas and in the breast. There is yellowish white firm deposits. The fat cell, these having the cloudy appearance, and it is surrounded by the inflammatory reaction. Important. Next is the fibrinoid necrosis. So in this, there is a deposition of a fibrin-like material. It is present in the immunological tissue injuries, the arterioles of the hypertension and the peptic ulcers. It appears like a brightly eosinophilic in the vessel wall. It is usually seen in the wall of the blood vessel, example in the vasculitides, and it is glassy eosinophilic fibrin-like material which is deposited within the vascular walls. And last is the gangrenous necrosis. So the gangrenous necrosis, it is of two types, the dry gangrene and the wet gangrene. It is most often seen on the extremities, usually due to the trauma or the physical injury. There are two types of gangrene, the dry and the wet. So the dry gangrene, it has no bacterial superinfection in which the tissue appears as dry, while in the wet gangrene, the bacterial, this is the wet gangrene, the bacterial superinfection has occurred. The tissue, it looks wet and liquefactive. Now let's discuss some very important differentiating features between the dry gangrene and the wet gangrene. So the dry gangrene, it most commonly occur in the limbs, and the wet gangrene, it is commonly occur in the bowel, and the mechanism, it is due to the arterial occlusion, and the most common cause is the wet gangrene, it is due to the venous obstruction and less often due to arterial occlusion. In the macroscopy, in the dry gangrene, the organ may be dry, shrunken and black in color, while in the wet gangrene, the part of the organ, it is moist, soft, swollen, and rotten and dark. The putrefaction In the dry gangrene, it is limited due to the very little blood supply, while in the wet gangrene, it is marked due to the stuffing of the organ with the blood. In the dry gangrene, the line of demarcation is present at the junction between the healthy and the gangrenous part. This is the line of demarcation. While in the wet gangrene, there is no clear line of demarcation. The bacteria, it is failed to survive in the dry gangrene, while in the wet gangrene there are numerous bacteria present. The prognosis is better due to the little septicemia in dry gangrene, while the prognosis is poor due to the profound toxemia. So this is all about the differentiating features between the dry gangrene and wet gangrene, very important for your MCQ. So after this, these are the type of necrosis we have already discussed. The coagulative. So the coagulative, it is the most common type. The loss of the nucleus with the cellular outline being preserved, associated with ischemia, seen in mostly organ like in heart, liver, kidney. Guys, very important, it is not seen in brain. The coagulative necrosis do not occur in brain. The liquefactive necrosis, it is due to the enzymatic destruction of the cell. There is abscess formation, pancreatitis, and it is seen in brain, the liquefactive one. While the caseous necrosis, it is the combination of the coagulative and the liquefactive necrosis. It has a cheese-like appearance of the necrotic material, characteristic of the tuberculosis. Important point. MCQ. Tuberculosis. It is also seen in the syphilis, histoplasmosis, and mycosis. While the fat necrosis, it has an action of the in this there is an action of the lipases on the fatty tissue. It is particularly seen in the breast and the pancreatitis. Important for your MCQ. The fibrinoid necrosis, in which there is a complexes of the antigen and antibodies. These are deposited in the vessel wall and leakage of the fibrinogen out of the vessel. So this is seen in the pan-Aschoff bodies in the rheumatic heart disease and the malignant hypertension. Very important. The gangrenous necrosis, it is surgically used the term necrosis of the tissue with the suprarenal putrefaction. The dry gangrene is similar to the coagulative necrosis. The wet gangrene is similar to the liquefactive necrosis, and it is due to the secondary infection. So the noma, it is the gangrenous lesion of the vulva or the mouth or the cancrum oris. The Fournier's gangrene, it is seen in the scrotum. Important. This table is very important for your MCQ point of view. So let's discuss some of the differentiating features between the apoptosis and the necrosis. So in apoptosis, only a single cell are affected, while in the necrosis, it affects the group of the neighboring cell. There are no inflammatory response in the apoptosis, while there is significant inflammatory response seen in the necrosis. There are cell shrinkage in the apoptosis, while there is cell swelling in the necrosis. The membrane blebbing but integrity maintained in the apoptosis, while there is loss of the membrane integrity seen in the necrosis. There is an increased mitochondria membrane permeability, which leads to the release of the pro-apoptotic proteins and formation of the apoptotic bodies in the apoptosis, while there is organelle swelling and lysosomal leakage, which is seen in the necrosis. So there is chromatin condensation and non-random DNA fragmentation, which is seen in the apoptosis, while there is random degradation of DNA, which is seen in the necrosis. The apoptotic bodies ingested by the neighboring cell in the apoptosis, while in the necrosis these are lyse cell. In this, the lyse cell ingested by the macrophages. Important. So after this, let's discuss the amyloidosis. So it is derived from a word amylum in Latin, which means amylin in the Greek, which means the cellulose or the starch like. Fine. So by definition, the amyloid refers to an abnormal deposit of the insoluble polymeric protein fibrils in the tissues and in the organs, and this condition of deposition of the amyloid in the tissue, it is known as amyloidosis. The fibrils are formed by the aggregation of the misfolded normally soluble proteins. The extracellular deposition of the fibrillar proteinaceous substances, these are known as amyloid. So in this, a waxy substance which is composed of essentially of an abnormal protein, particularly around the supporting fibers of the blood vessels and the basement membrane. See, this is the structure of an amyloid. So this is an electron micrography of 7.5 to 10 nanometer in which there are amyloid fibrils. And very important, commonly asked MCQ, that this is a Congo red staining which shows an apple green birefringence under the polarized light, a diagnostic feature of the amyloid. Very important. So on the electron microscopy, these fibrils, these are continuous, non-branching, insoluble, linear, rigid, and measure about 7.5 to 10 nanometer in diameter. So on X-ray crystallography, it is a characteristic of the beta pleated sheet. These are the beta pleated sheet conformation. Beta pleated sheet conformation, important for your MCQ. So after this, let's discuss the chemical nature of the amyloid. So in this, there are three components, in which first is the afibrillary protein, which constitutes about 95%, which is the characteristic for each different type of the disease. The amyloid P component, which constitutes 5% of the total, and it consists of the stacks of the donut shaped protein. All the different types of the amyloid possesses this protein, while glycosaminoglycan, this is a part of a molecule which is responsible for a positive reaction of the iodine. Important. All these 3 points are very important for your MCQ. So the most common form of the amyloid, see, there are two types of protein. The fibril protein and the afibrillar protein. So first we are going to discuss about the fibril protein. So in this, the most common form of the amyloid fibril protein are AL, which means the amyloid light chain, and it is made up of a complete immunoglobulin light chain. It is derived from the lambda light chain, from the very important lambda light chain. Second is the AA, which means the amyloid associated. It is derived from a unique non-immunoglobulin protein which is made by the liver. It is derived from a larger precursor protein SAA, which means the serum amyloid associated protein, and other. Important. Next is the A beta 2 microglobulin, which is seen in the patient on the long term on the hemodialysis. TTR, it means the transthyretin. It is a serum protein synthesized in liver and transport the thyroxine and the retinol. While fifth one is the A beta, it means amyloid beta peptide, is seen in the Alzheimer's disease. While APRP, it means the prime proteins, the precursor of the AA, which means the amyloid associated is equal to the SAA, which means the serum amyloid associated protein. So the precursor of AA is equal to the SAA. Important. So these all are the fibril protein. Coming on to the non-fibrillar or afibrillar proteins. So non-fibrillar amyloid proteins, these are the AP. It means amyloid protein component which is found in all the form of the amyloid. The apolipoprotein, which is the E or the ApoE. The sulfated glycosaminoglycans, which is GAGs. The glycosaminoglycans. These three are the non-fibrillar amyloid protein. So after this, let's discuss the classification of the amyloidosis. So it first is on the basis of the cause, or based on the cause. It can be primary or secondary. The primary, in this, the cause is unknown and there is a deposition in the disease itself, while the secondary, it is act as a complication of some underlying unknown disease. Second is on the basis of the extent of the amyloid deposition. So it can be systemic and localized. So in the systemic, it involves the multiple organ, while in the localized, it involves the one or two organ or sites. So third is on the basis of the histological basis. So it can be pericollagenous and perireticulin. So in the pericollagenous, it is corresponding in the distribution to the primary amyloidosis, primary one, while in the perireticulin, it is corresponding in the distribution to the secondary amyloidosis. Based on the clinical location, so it can be of 3 patron, either patron 1, patron 2 and mixed patron. Patron 1, it very important. It involving the tongue, heart, bowel, skeletal and the smooth muscle, skin and the nerves, while patron 2, it principally involving the liver, spleen, kidney and adrenals, while the mixed patron, it involving sites of both the patron 1 and patron 2. Next is on the basis of on the tissue in which the amyloid is deposited, the mesenchymal in which the organ derived from the mesoderm, the parenchymal in which the organ derived from the ectoderm and endoderm. Next is on the basis of, or it is based on the precursor biochemical protein into specific type of the serum amyloid protein. Next is the classification of amyloidosis, which is very important. It can be systemic, it can be localized. So in the systemic or the generalized amyloidosis, first is the primary, which is associated with the plasma cell dyscrasias, and the biochemical type is AL type, and the organ involved are heart, bowel, skin, nerve and kidney. Secondary or the reactive, the associated disease is chronic inflammation and cancer. The biochemical type is AA type, and organ involves are liver, spleen, kidney and adrenals. While third is the hemodialysis associated, the disease associated is the chronic renal failure, and biochemical type is A beta 2M, and organs involved are synoviums, joints, tendon and sheath. While the heredofamilial, in which first is the hereditary polyneuropathies, in which there is no associated diseases, biochemical type ATTR, and the organs involved are peripheral and autonomic nerve and heart. The familial Mediterranean fever, there is no associated disease, it is of AA type, and organ involved liver, spleen, kidneys and adrenals. The rare hereditary forms, there is no associated disease, and the biochemical type is AAPOAL. The AGL, AL, A-lysis, AFIB and ACYS. So it is commonly involved the liver, spleen, adrenal, systemic amyloidosis. While the local amyloidosis, it may be senile cardiac, which includes the senility, and the biochemical type is ATTR, which means the amyloid transthyretin, and it is commonly involved the heart. The second is the senile cerebral. The associated disease is Alzheimer, transmissible encephalopathy, transmissible encephalopathy, and it involves the A beta and APRP, which means the amyloid of the prion protein, and commonly it involves the cerebral vessel plaques, neurofibrillary tangles. The endocrine, the disease associated with is the medullary carcinoma, type 2 diabetes mellitus, and Biochemical type is the calcitonin and proinsulin. And procalcitonin, it includes the thyroid, and proinsulin, it includes the Isles of Langerhans. Last is the tumor forming associated disease are the lung, larynx, skin, urinary bladder, and tongue and the eye. While the biochemical type, it includes AL, which means the amyloid light chain, and the organ involves it is respective anatomic location. It involves the respective anatomic location. So after this, let's discuss the epidemiology. So it is most commonly occur in the middle age and more commonly occur in the males than that of the females. Most common type is AL amyloidosis, then AA, and then ATTR. Important. So the amyloid associated protein, it is second most common type worldwide, but prevalence rate are presumed to be higher in the developing countries. Coming on to the risk factors, so it is usually occurs at more than 50 years of age but equal to 65 years. It is mostly due to the risk factor is the family history, the hereditary types. The race is ATTR, which means the amyloid transthyretin. It is most common among the Hispanic population. Males predilection, it is more than that of the female. Chronic inflammatory conditions are seen. Associated history of the multiple myeloma, which is most commonly seen in 10 to 15% of the cases. It is long term in the patient with long term hemodialysis and the ingestion of the amyloid fibers in the meat of the animals which are affected with the disease. Next, let's discuss the pathogenesis of the amyloidosis. So this is the production of the abnormal amount of the protein which leads to the unknown etiology, which leads to the carcinogen, leads to the formation of the monoclonal B lymphocyte proliferation, which leads to the plasma cell, and there is immunoglobulin light chain. With the limited proteolysis, it leads to amyloid light chain. Fine. There is a stimulus which leads to the soluble precursor misfolded protein, which leads to the insoluble fibrils. While in the chronic inflammation, which leads to the macrophage activation and then there is interleukin 1 and 6 in the liver cell, and there is an SAA protein. Fine. With the limited proteolysis, it leads to the AA protein, which is the amyloid associated protein. And the production of the normal amount of the mutant protein, example the transthyretin or the transthyretin. In this, there is a mutation which leads to the mutant transthyretin. With the help of the aggregation, it leads to the ATTR protein, which ATTR is amyloid transthyretin. Right. So after this, let's discuss the clinical features and the complication. In this, the clinical suspicion, it is unexplained nephropathy, cardiomyopathy, neuropathy, enteropathy, arthropathy, and the macroglossia. So in this, the kidney and the heart, these are most commonly involved. Important. The two organs which are most commonly involved, these are kidneys and heart. So the renal, it constitutes 33 to 40%, in which there is proteinuria, which leads to increase in the urea and increase in the SCR. There is renal insufficiency, which is a rare complication. In the cardiovascular, in the heart, it may be present with either diastolic or systolic heart failure. The RV dysfunction more commonly than the right RV is the more common than that of the LV dysfunction. So it may also cause the conduction abnormalities, example the atrioventricular block, the sinus node dysfunction, low voltage complexes on the ECG. Important. Now next is the cardiovascular or the blood vessel. See, there is an increased susceptibility to the bruising and the bleeding around the eyes. This is what we call as the raccoon eyes. So it is caused by the deposition of the amyloid in the vessels around the eyes, which leads to decreased activity of factor number 10 and the thrombin. Very important. Next is the macroglossia, large tongue. It is less than 15% of the cases, less than in the 15% of the cases, and it may be due to the accumulation of amyloid in the tongue. It leads to dyspnea, obstructive sleep apnea, dysphagia, dysphonia, siluria, or the siluria, angular cheilitis, the crenated tongue, and the orthodontic abnormalities. While in the nervous system, in the central nervous system, it is dementia in the Alzheimer's disease and the Down syndrome, the hemorrhagic strokes, which is 2 degree to the cerebral amyloid angiopathy. While in the peripheral, this is the CNS and this is the PNS, peripheral nervous system, there is a peripheral neuropathy in which there is autonomic neuropathy, example the postural hypotension and the GIT symptoms. Important. Next is in the liver. In the liver, when there is amyloidosis in the liver, there is a liver enlargement, there is an increased alkaline phosphatase and increased transaminases. In the spleen, there is a splenic enlargement which is occur less than 5% of the cases, while the splenic dysfunction, it is occur more than 25% of the cases. In the GIT, the amyloid deposits seen in 80 to 90% of the cases, only 1% are symptomatic, and in the malabsorption also. Very important. In the musculoskeletal, you can see the shoulder pad sign. In this, there is enlargement of anterior shoulder due to amyloid deposition in the periarticular soft tissue. MCQ. So, involvement of the synovial space may result in the chronic synovitis, which is the carpal tunnel syndrome in the wrist. On the skin, there is macular rash on the interscapular region of the back, which is the maculomydosis. The lichenoid papules, these appearing bilaterally on the shins, which is known as lichenoid amyloidosis, while the nodules involving the acral area, it is known as nodular amyloidosis. It is a rare presentation. Important. Now coming on to the diagnosis of the amyloidosis. So in this, first is the biopsy examination. It is the most common and the confirmatory method for the diagnosis of the suspected case of the amyloidosis. So in vivo Congo red test is the confirmatory test. Very important and mostly asked MCQ, commonly asked MCQ. So other tests are the supportive of the amyloid disease, the electrophoresis, immunoelectrophoresis of the urine and the serum, and the bone marrow aspiration. But the confirmatory test is in vivo Congo red test. The fat pad biopsy. So in this, the fat aspired from the abdominal wall, it is most easily accessible tissue, and the biopsy is positive in more than 80% of the patient with the systemic amyloidosis, in which the rectum, there is a salivary gland or the gingiva and leads to internal organs. Coming on to the pathological effect of the amyloidosis. So there is an amyloid deposition which creates the pressure on the adjacent cell, which leads to atrophy, while the amyloid deposition on the blood vessel, it leads to the narrowing and it leads to the increased permeability, which leads to the transduction of the protein out of the vessel. Important. Next is the amyloidosis spleen. So this is the pink cellular amyloid material. This is the pink cellular amyloid material which is seen in the red pulp causing the atrophy of the white pulp. This is the Congo red stain which shows the Congophilia as seen by the red pink color. When viewed under the polarizing microscopy, the corresponding area, it shows the apple green fringence, bifringence. Important. While the amyloidosis of the liver, in these are the atrophied or the atrophied hepatocyte. The deposition is extensive in the space of the dice, causing the compression and the pressure of the atrophy of the hepatocyte. These are the hepatocyte. The Congo red staining, it shows the Congophilia, which under polarizing microscope, while it shows apple green bifringence. Fine. So guys, this is all about the cellular or the cell pathology. Please go through it once and try to make the notes. Thank you.